Welcome everybody to our presentation for week 2 on billing and coding. This is hopefully will be helpful to everyone who is perhaps not knowledgeable about billing and coding in the healthcare environment. If you are knowledgeable, hopefully it won't be too boring for you. I'm really just going to give a bit of an overview. If you are super knowledgeable in this area, you know it might be something that you could perhaps skip if you happen to work in billing or coding. I'm just going to give a bit of an overview of some billing and coding. Just really a high-level overview of billing and coding in the hospital and physician world. I'm not going to give details. You're not going to walk away from this being able to open your own billing or coding business or anything like that. This is the area that I actually really work in. I teach billers and coders full-time all across the country. So I have tons of extra details that I'm happy to share with you. If this spurns a big interest in these areas, please let me know, and I'm happy to talk with you further about these areas. So, billing for services generally comes in a bazillion different forms. The billing that we do in the healthcare environment varies based on the type of service that's being provided. So, obviously we have services in the hospital setting, physician or provider setting, laboratories, freestanding radiology type services, and other institutional providers. So things like skilled nursing facilities, nursing homes, long-term care facilities, all of these different types of facilities, and they all vary in the way that they bill. But the one thing that you'll see as we move forward in our presentation is that it really, kind of boils down to two main types of billing, and I'll kind of refer to them as hospital and physician. And it's really because there are two main ways that we submit claims. We either submit them on an institutional claim or on a physician claim, and it's really that in the billing world, we really refer to them as hospital or physician. And those are because the bulk of providers in this country are either hospitals or physicians. So that's why they get referred to in that way, not to pay less credence to other providers like laboratories or places like long-term care hospitals or skilled nursing facilities, but just because the bulk of facilities that we think of are hospitals or are physician practices. So it's not that the others are less important in any way, but they just tend to fall into one bucket or the other. So although they do come in many forms, they tend to fall into one bucket or the other, that hospital bucket or institutional bucket or the physician or provider bucket, as we'll see as we move forward. So we have kind of, like I said, those two billing formats, that hospital bucket or that physician bucket. So that first bucket, the hospital services bucket, they're billed on what way back in the good old days, and most of you probably aren't from the good old days like me, but back in the good old days, we actually used to type claim forms on paper. And when they were typed on claim forms, on paper claim forms, they used to be on what were called uniform bill forms, UB forms. And those UB forms had a number. It was based on the year that they were released. And the current form that we're using is the UB04. So the UB04 form is actually the paper claim form that if we still submitted on a paper claim form, it would be the UB04. But we actually don't submit on paper claim forms anymore. We submit on an electronic claim. Some physician practices actually still do submit on paper claim forms, believe it or not. Very, very small ones are allowed to, and some of them do. But generally, we submit on electronic claims, and they submit on what's called an 837I electronic claim. It's an institutional claim submission, the 837I, and And with hospital services, this is one thing that differentiates them from a physician service. Generally, a hospital is going to place every single service that they provide on that claim, whether those services are going to be paid or not, because hospitals want to represent all of their cost on that claim. They want to make sure that they're representing every single penny that they have spent on that patient, because they want to make sure that it's all accounted for on their claim. So that's something that makes them a little different than physician services, and we'll talk about that in a second. So the UB04 is the kind of the claim format that we'll see in the hospital side of things, and hospitals, institutional providers will typically represent all services that have been provided. So you'll see every single aspirin that was provided to a hospital patient, all types of services that were provided to a hospital patient will end up on that claim, even though all of those items may not be paid by the insurer in the long run. Now, in the physician world, on the physician side of things, and the folks that are billing on physician claim forms, or the CMS 1500 they're called, are physicians, obviously, but also most other types of outpatient providers. So, for example, if you're a freestanding physical therapy practice that's not affiliated with a hospital, say just a private physical therapy practice in the community, or any type of that type of a freestanding therapy practice, like counselors, mental health counselors, a group of nurse practitioners that maybe has come together and is working but aren't physicians, they're nurse practitioners. Those types of folks will all also use this same type of a format for their billing. And back in the day, the paper claim form that we used was a CMS. CMS is the Center for Medicare and Medicaid Services, and you probably saw that in your reading this week. CMS. And way back in the day, it was the 1450. I'm sure back before that, there were they used to be known as HCFA, which was the Healthcare Financing Administration, the precursor to CMS. It was the HCFA 1450. Then it became the HCFA 1500. Then it became the CMS 1500. But that was the paper claim form, and it is still the paper claim form that is used for folks that are billing on that paper claim format. And like I said, there are still a very limited number of people that can bill on this paper claim format. But the majority of folks are using those electronic transactions, and it's that 837P, P for physician, provider electronic transaction. And the reason that we're using these very specific electronic transactions, and they follow this very specific type of transaction, this 5010 transaction format, is due to HIPAA. And obviously we're learning about HIPAA and whatnot as well in our course. HIPAA requires that we follow a very specific electronic transaction format. They also require that we use specific code sets in our transactions, and we'll talk about which code sets when we get to the end of our presentation. But HIPAA really governed billing and coding from a transaction and code set standpoint to make sure that we were all doing things the same way and hopefully standardize things for us. So the one thing that is a little bit different in the physician world from the hospital world is that unless a provider is billing an insurance company for a denial, like in other words, if they know that a service is non-covered, and they need to get a denial, maybe to submit to a secondary insurer or something like that, typically a provider is not going to submit non-covered items on a claim. So, for example, if a patient comes in and gets a bunch of services that are non-covered, like a bunch of cosmetic procedures, or comes in and buys a bunch of supplements from a provider that happens to sell supplements, and those items are non-covered by your insurer, typically the physician is not going to be submitting those items to the insurance company. They're not going to end up on a claim. So that's where billing in the physician world is a little bit different than billing in the hospital world. Hospital's always going to represent all of their cost on the claim, even if it's not something that is covered by the insurer, and the insurance company will parse it out and figure out what they're going to pay and what they're not. In the physician world, typically the physician is not going to be listing items on the claim that they know are non-covered. If it's something they're not sure is covered or not, then obviously they will bill that and let the insurance company figure it out. But if it's something that they know is a non-covered service because it's statutorily excluded from the plan, then they likely will not be reporting that on the claim. So how is billing done? How does this process work? Well, it usually starts with coding. We'll talk a little bit more about coding, the codes themselves in a moment. But coding can happen in two different ways. In the hospital world, it happens in one of two ways. It can happen through the charge master, and in the charge master, what the charge master is a giant list of codes, and these codes are hooked to, really what the charge master is a giant price list. It's the price list of the hospital for many items, and it has the price of the item as well as the code for that item. And what happens is perhaps, let's say it's a good example is in the GI lab. This often happens in the GI lab. So the nurse in the GI lab, patient comes in for upper GI endoscopy. And let's say they had an endoscopy with a biopsy of their esophagus. And so the nurse knows that that's the procedure that was done. Oftentimes, unfortunately, the compliance officer in me does not like this very much, but oftentimes, unfortunately, these items are not coded by coders, but someone in the GI lab just makes the choice of the code, and hopefully, sometimes it's the nurse, so the nurse actually knows what was done. So the nurse will look at the items in the charge master, and they'll say, oh, okay, well, this item says upper GI endoscopy with biopsy. This might be the right one. So hopefully it's a nurse, they're clinically knowledgeable, they'll make the right choice. So they'll look through the charge master, and they'll make the choice, and then that's how the charge is assigned. So in some cases, that's how it works. Other cases, like in the laboratory is a good example of where things are hard-coded, meaning that it comes out of your charge master. And a lot of times, the machines themselves are making the coding choice, meaning that when the lab information system spits out the results, because the lab information system is really what's calculating the results for you, it knows what test was done, so it actually codes it for you and assigns a charge. So sometimes the machinery itself is pretty smart. But also in hospitals, they have what's called soft coding. And soft coding means that a coder is coding it. So a certified coder, usually in a hospital setting, they can be certified by a couple different agencies, the American Health Information Management Association, or AHIMA, or by the American Academy of Professional Coders, less often by them in the hospital setting. I actually have coding certifications on both sides, so I'm covered both ways. But coders can be certified by either organization, and so these coders will look at the medical record documentation and make a choice based on what's in the medical record documentation of what code was done. We'll talk about the codes momentarily, but so they'll take a look at the coding. And when we're talking about codes here, we're talking about procedure codes. So what procedure was done? Then the diagnostic coding, the diagnosis coding, can come from a couple different places as well in the hospital setting. If it's an order for like a laboratory test, those codes are going to come from the person that ordered it. So if it's a laboratory test, the person that ordered the lab is going to provide that. But if it's a surgical procedure, then the person performing the surgery is going to tell us what the diagnosis was. And then again, oftentimes it needs to be soft coded, or a code needs to be assigned by a coder. That coder usually works in health information management. So in the physician practice setting, where do these codes come from there? Well, in the physician practice setting, they are typically what's called soft coded, but they can be soft coded by a couple different people. Sometimes they're soft coded by the providers themselves, which can lead to some compliance issues because providers are notoriously bad coders. So this can lead to compliance issues when they're not being very good at their coding. So this can lead to some compliance issues down the road when they're not coding things properly. Or you can have certified coders in the physician office setting. Especially in a surgical practice, you'll often find certified coders. Or sometimes you'll have just folks that work in the practice, perhaps like an office manager or billing staff, that are knowledgeable of coding, and sometimes they'll be in charge of coding things. So sometimes that's the situation. So it depends on who's assigned to coding records. There's been more of a push to have certified coders coding records in the physician practice setting, and from a compliance perspective, that's obviously the best option. So once codes are assigned for both diagnoses and for the procedures or services that are provided, then charges are assigned. Depending if charges haven't been assigned, then charges are assigned. Then everything is typically run through editing software and what's called scrubbed. So a claim scrubber. And it's scrubbed to make sure that everything that's on that particular claim can be billed together. Sometimes there are issues where certain items can't be billed with other items. So a good example, I'll use a surgical example. If you have an abdominal surgery, let's say you have a cholecystectomy, which is when you have your gallbladder removed. So let's say you have your gallbladder removed, and while they're in there, they just happen to take out your appendix, just so you don't have a problem with that down the road. There are two separate codes for those two separate services. However, billing and coding rules tell us in the billing and coding world, coders know that you can't code those two things together. The rules tell us, unless there is some kind of an extenuating circumstance, like for example they got in there and they saw that your appendix was inflamed or had ruptured and there was a medical reason for taking out your appendix, we know as coders that you cannot code those two things together, that it would be considered unbundling and it would be inappropriate to code them together. So when you run that, if you were to code them together, if a coder was to code the two of those items together and it was run through that claim scrubber or that editing software, that thing would pop back out. It would show as an edit. So then, the next step is your issues need to be addressed. And then obviously a biller / coder is going to review anything that pops back out at you, any edits that come out. All of those items need to be addressed. Hopefully none will be addressed and you have all clean claims. And then you can go ahead and submit your claims. I put the question clearinghouses here because what a lot of places have is what's called a clearinghouse. And I didn't double check your book. The clearinghouses may be addressed in your book. A lot of places use clearinghouses for both claim scrubbing as well as claim submission. So rather than submitting directly to the insurers or rather than scrubbing claims themselves, providers will often submit their claims to this kind of independent third party. And they'll submit their claims to this what's called a clearinghouse. The clearinghouse may scrub the claims for them, get them packaged up and ready to go, and then submit them off to the payers on their behalf, on the provider's behalf. And then they'll also run the editing reports and let the provider know what claims have issues, etc. So they kind of serve as a go-between between the payers and the provider and manage all of that process for them. So a lot of providers do use clearinghouses for that service. So coding systems, our last little bit here. Coding systems, there are specific coding systems that were spelled out in HIPAA when it was passed many years back. And they told us these are the coding systems that you need to use for the specific areas of of coding in these different situations. So for hospitals, they told us that you need to use ICD-9 volumes 1 and 2 for your diagnosis coding. So when we have diagnosis codes, you need to use ICD-9 volumes 1 and 2 to spell out those diagnosis codes. And these are between 3 and 5 digit numeric codes for the most part. There are some codes that start with letters, but generally between 3 to 5 digit numeric codes. And they spell out the diagnosis for the patient. For inpatient claims only, we use ICD-9 volume 3 to spell out the procedures that are being performed. So this is just on hospital inpatients, just being billed by the hospitals themselves. We use ICD-9 volume 3 codes. So it's very limited use code. For outpatient services, to spell out the procedures being performed, we use CPT, which is a code set that is maintained by the American Medical Association. It's more famously known for physician use, but we use CPT, and it's also not so commonly known as HCPCS Level 1, but CPT, it's like I said, regularly used in the physician world, but CPT codes, and then also HCPCS Level 2 codes, which are also used for procedures and services in the outpatient world. So inpatient procedures, inpatient procedures are ICD-9 Volume 3. Outpatient procedures and services are CPT and HCPCS Level 2, and that's in the hospital side. On the physician side, things are a little bit different. So HIPAA told us that for diagnoses, again, we use the ICD-9 CM volumes 1 and 2, and that's our diagnosis codes. And then for procedures and services, physicians are to use that CPT code set, which is what the AMA maintains. And then HCPCS Level 2, for procedures and services as well. The ICD-9 code set and the HCPCS code set are really maintained by government agencies, whereas CPT is wholly owned and operated by the American Medical Association. So it's a little more difficult, it's more expensive. The other ones are public use code sets, whereas CPT you have to purchase. So it's a little bit different. Now, there's, if you're currently working in the healthcare world, you may have heard a bit about ICD-10. And what is the deal with ICD-10? We were supposed to be making a change in code sets effective in just a few months. We were supposed to, it's probably one of the biggest changes in the reimbursement and coding world ever. I've worked in this industry for over 20 years, and it's definitely the biggest change that's ever come about since I've been in this industry. We were supposed to make a change coming up October 1st of 2014, and back about April, end of March, beginning of April of this year, there was a law that was passed that delayed this again. It's been delayed previously, and now it's been delayed again. And what this is the ICD-10 code sets. There's two of them, ICD-10-CM and ICD-10-PCS. We're doing away with the ICD-9 code sets, volumes 1, 2, and 3. So all of the uses that we talked about here for the ICD-9 code sets were all going away. No more diagnosis codes, no more inpatient hospital codes being used out of ICD-9. So, the ICD-10 code sets were supposed to come into effect October 1st, 2014. A law was passed. It was tagged on to a sustainable growth rate law to help out physicians for Medicare. It was tagged onto that law, just one line that they kind of stuck in there. Effective, the law came about in March, beginning of April. And at that point, it was delayed indefinitely. They've recently passed a regulation that is now making the ICD-10 code set effective to replace the ICD-9 code sets effective October 1st, 2015. I'm not going to say that it will definitely be effective October 1st, 2015, because there's nothing to say that Congress can't come out and pass another law that says that the Department of Health and Human Services again cannot implement the code set. There's clearly a push out there of a large group of people that do not want this code set to be implemented. But the things that the ICD-10 code set can do for us are amazing, from a research, quality assurance, and there's just an innumerable number. It's kind of redundant, but there's a number of perspectives where this code set can be helpful outside of just reimbursement. And the millions and millions and millions of dollars that have already been spent by hospitals and physician practices to make this transition would all be lost. Just folks that have spent money with my company, having me and my colleagues come out and train them on ICD-10 alone is ridiculously high. So I can't imagine multiply that by all the companies that are out doing this type of training and preparation. So that's ICD-10. So if you've heard of it, that's, hopefully provide you a little update. And so we'll keep our fingers crossed that we're going to go live October 1st, 2015. And there is apparently a law that is currently sitting in committee right now that will put the kibosh to it again, but it's been in committee since 2013, and I don't see it going anywhere, but apparently some agencies are keeping an eye on it to make sure it doesn't go anywhere. But we'll see how that goes. So those are the coding systems, and like I said, there's different ways they can be applied, either via ChargeMaster or via coders, lots of different ways. But those are the code systems that we must use. So that is billing and coding in a nutshell. That's a lot of information in a short period of time. But I do encourage you to take a look at the payment information and the different the different third-party payers in your reading material for this week, and then kind of think of that in conjunction with this information. If you have questions on how the two are kind of connected, let me know. And if you have additional questions on billing and coding, or if you have a specific interest in these areas, please let me know. Like I said, this is kind of my bread and butter, so I'm happy to share more information about it. And that's all we've got on that. So thanks so much, and we'll talk to you in the classroom this week.